Hey everybody, Professor Finn here. Right now we're going to look at vessel site and selection, which is chapter, I believe, 9 in your embalming book. So let's go ahead and dig in. Choosing the right artery is important, as you can probably imagine, which is what this slide says. The other thing that comes up is where you start might not be enough. You might have to adjust your game while you're playing. So where we start might be ideal, and then we realize that as we're doing things, it is more complicated than we thought when we adjust our game plan. So the 1 point, an artery and a vein at a single location are used for injection and drainage. Now, I tell my students in class, I'm telling you here now in the online lecture, feel free to touch yourself in these places. You know, you got two hands, and if both fingers point to the same area, it's probably at 1 point. So if we were to say injecting the right common carotid and draining the right jugular, you have a right and left index finger. They're both pointing right now to the base of your neck in the same place. That's going to be your 1 point, okay? Now, when we look at a split injection, which is the very next thing, an artery is injected at one location, vein is drained for a different location. So if we say, hey, right hand points to the right common carotid artery, my vein is my left femoral or my right femoral, my fingers are in two different places. Don't fall for the trap where it says, okay, I'm going to inject via my left axillary, okay, which would be my armpit, and then I'm going to drain via my left basilic, and I'm now pointing, you know, my other hand, which you can't do because it is what it is. I am looking at my bicep. That is not a single point injection. You would have to inject and drain both from the axillary artery. The same thing could also theoretically be if we are injecting via the right inguinal, okay, and we are draining via the right femoral. That would be two different locations potentially. So you'd want to comment on that and say, hey, you know, sometimes this is known as the iliofemoral. If we're looking at both in the same area, then yeah, you know, that might be a single point, but realistically it's one artery, a different vein, and you have a split point. Restricted cervical. Obviously, the book really, really likes restricted cervical. The way this happens is we raise both common carotid arteries, left and right, okay? An arterial tube is inserted towards the trunk on one side, and the remaining artery is tied off at the bottom. Drainage is usually taken at the right jugular. So what would happen if I have my neck, okay? Here's my neck, here's my head. I'm going to raise both of these arteries. I am then going to keep this open and tie this off, okay? So the only thing I'm going to be able to do is go up this way on this side. On the other side, I am going to be able to go up and down. So why do we tie off this artery right here? Okay, why do we tie this one off? Well, think about the anatomy. What's going to happen is this is going to come down. Oh, look at the heart, yay! We have the ascending arch of the aorta, descending aorta, and we have the terminal branches. So we have one that goes this way, we have one that comes up this way, and one that comes up this way. If we do not tie this left common carotid artery off, the fluid's going to come right out and start spraying everywhere. The whole goal of this, okay, the whole goal of this is to make sure that the head itself is isolated from the rest of the injection. Advantages of this. Well, there's a lot of advantages. Make sure you look these up. But realistically, when it comes down to it, it's so that we can separate, quote unquote, the head from the body so that we can utilize techniques for the body and techniques for the head without worrying about a whole lot of problems with the head. A multipoint is an ejection from two or more arteries. So a true split point, okay, involves injecting at one site, right common carotid, draining from an alternate site, and we'll say for sake of argument, left femoral artery, okay? And the instant I go from that to, oh crap, I got to inject my right femoral artery, I've now gone into a multipoint, okay? You cannot look at a multipoint just when someone gives you one artery and one vein. It requires more than one injection site. This leads us then to the 6-point or sectional embalming. On an unautopsied body, this is not really complicated stuff, okay? 6 points, both on the head, both arms, both legs. Shocker, okay? Shocker. Where it changes the game a little bit is with what we can access with an autopsied body. So both carotids remain the same. Both subclavians, okay, if we need to, or axillaries, brachial, something in the arms, whatever we can find, both femoral or external iliacs, okay? So the only thing that we kind of add with the autopsy body is the subclavians, because those can be found with the flaps open. Drainage can be taken from each location if you want. It can be taken from a central location. Does not matter. Do not confuse the 6-point with an autopsied body. It is most commonly associated with it, yes, because we have to. But people say, oh, well, you're not going to have a 6-point on a regular body. Yes, you most certainly can. And if you want to be really anal about it, you could even drain from every place that you inject. So if you're injecting the right common carotid, you drain from the right internal jugular. Go to the left side, you do the carotid and the jugular on that side. You go to the right arm, you start with the right axillary, drain from the right axillary vein. So you can do all of that. That would be extremely time consuming. And chances are your owners would be very disinclined to give you that time to do it just because you think it's cool. Trunk of the body can be injected from any artery, okay? Does not matter where you inject the trunk from, obviously, as long as you do. And you can also do the proverbial 12-point, okay, the 12-point, if you inject towards the trunk at all the locations. So you inject towards the center, up and down, at both necks. You do towards the center and towards the hands on both arms, and towards the feet and towards the torso from both legs. You have a 12-point injection. Do the math. So how do we select the right one? Well, it's important because choosing the right artery and choosing the right vein go a long way with getting our job done right. Common arteries of the unautopsied body, no-brainer. The ones in the neck, the ones in the leg, and the armpits. Carotid and femoral are generally the most preferred because of the large accompanying vein. Being able to access a vein at the injection site is important for one basic big reason. You don't want to make extra cuts if you don't need to. This reduces leakage. This is less liability. You are less liable to find yourself in a hot water for mutilation because you've been making excess cuts. So realistically, the accompanying vein is a major criteria for selecting the artery. Once injection begins, you have to pay attention to what's going on and then change your game plan as necessary. And this will continue. You are obviously analyzing before you inject, choose what artery. You use the artery. And then once you're done injecting, you look at the body and go, did it work? If not, what else do I need to do? And you're going to do this sort of thing for both autopsied and unautopsied bodies. You're going to find that if you're right-handed, you like working on the right side. If you're a lefty, you work on the left side. It is what it is, okay? The right internal jugular vein leads directly into the right atrium of the heart, which is why the split injection exists. We can get the best drainage from that vein, but what if I want to inject from somewhere else? It is what it is. Most of the people who are quote-unquote leg embalmers will inject and drain from the femoral first and then take drainage from the neck later if they have to. There's lots of schools of thought, lots of preferences. It just kind of is what it is, and that's part of the art rather than the science. So looking at the injection site, okay, we're going to look at factors concerning condition of vessels. So from our embalming analysis, which we're going to study in Chapter 10, we're going to see, okay, what am I looking at as a body? Do I think diabetes? Do I think this? Do I think this? And then what are my best sites as a result of other conditions of the body? Do we see obesity? Do we see emaciation? Do we see this? Do we see that? Do we see a person missing limbs? That would obviously, you know, if you're missing a right leg, you are probably not going to want to be injecting via the right femoral artery. You might have to look for severed or cut arteries as a result of an autopsy. And there are, you know, some common sense reasons why you might have to do that. All arteries, veins, and nerves tend to be grouped together, so it's important that you can differentiate between the three. This is something that you will perfect throughout your time as an intern or as a resident. If you're already working on a pre-employment apprenticeship, this is one of the factors you should be paying attention to. If you only get to do a couple things in lab, the most important things that you can do is recognize a vein, a nerve, and an artery by sight, then by feel. Nerves, silvery appearance, show striations. They do not have a hole down the middle, okay? They do not have a lumen. When you cut them, they fray like a piece of rope. When you roll between the fingers, it remains solid, and there is no blood present. Generally, this is what you confuse an artery for. Veins are thinner, bluish appearance if it contains blood, deoxygenated blood. Contains valves. They're a one-way street, okay? They have a lumen. They have a hole. It's how we get the drainage in there. When you open a vein, when you cut it, it collapses, creating a funnel effect. It starts pulling in two different directions. When rolled between fingers, it collapses completely. You really cannot feel edges on veins. And if there is blood or clots, they're usually found on this side, okay? Artery, thick walls, creamy white in color, have small vessels or vasa vasorum. These are little veins that feed the arteries themselves and keeps the tissue healthy. When you cut it, the lumen stays open and pronounced, unlike the vein, which collapses. Carotids are more elastic than femorals. The way you remember this is above the belly button, it is generally more elastic than below, okay? Like the other rule of thumb. Do you remember the rule of thumb between above belly button and lower belly button? If it's above the belly button, chances are the vein comes first. If it's below the belly button, chances are the vein comes after. And the reason being is there's a lot more pressure closer to the heart, so things have to be a bit more flexible, whereas when you get down away from the heart, things need a bit more rigid to maintain pressures. Generally, arteries are empty of blood, generally. So selection is based on the following questions. How superficial or deep? Arteries in the abdomen or thorax are best for children. However, if we want to get to them, we have to open up the abdomen or the chest, pull out viscera, or carve into the pericardium so that we can actually get to items. We don't necessarily want to have to do that on an adult where we have a lot more problems. The sternum is calcified, so getting in that way is going to be problematic. Going in through the abdomen means pulling out intestines on an adult. That's like 30-something feet of small intestine. We really don't want to have to deal with it, even though it might be ideal. What structures are around it? How close to the aorta, the center of distribution? Remember the arch of the aorta. What is the size of the artery? Carotid is the largest. Femoral is medium. Axillary is generally the smallest of the common arteries that we deal with. Any artery, the artery, right? Any artery can be used to inject a whole body, but smaller arteries may not be able to provide pressure for effective distribution. We can inject the entire body via something like the ones found in your wrist, the radial or the ulnar arteries. But getting pressure so that it actually does something, that's going to be a problem. Once I use an artery, am I going to run into positioning problems? And when I am done, are those incisions going to be exposed? Someone brings in a strapless dress, okay? You are going to have serious considerations with, what arteries you can choose. You're going to want to start with femorals so that there is no incisions visible above the breastbone. Can I take the drainage from the vein? If clothing is present, where will the clot, or if clotting is present, where will the clots move during injection? Are they going to block other arteries, which may cause problems? And generally, how sclerotic is this artery? We might want to consider the age of the deceased. Infants require different arteries than adults because everything is smaller. So even the largest ones, the largest arteries, can be problematic to inject with, which is why we go for the abdominal or ascending aorta. Elderly may have tons of sclerosis in the femorals. There might be very brittle walls. You might have buildup on the inside of the arteries. Male and female matter, especially with clothing. Weight. Obese bodies have deep femorals, so the external iliac is better because it's much more superficial and generally don't have to go mining through all the adipose in the legs. Weight of the body is also going to cause issues, which may inhibit drainage and distribution. So now we're looking at even multi-point injection. We're going to have large quantities of fluid injected. Obese bodies may require restricted cervical or at a minimum facial injection first to phase freeze it. And then emaciated or thin bodies reflect damage to muscles easily. So if you're going in there with your blunt dissection instruments and tearing things apart, you might wreck the overall appearance of the neck by shredding those muscles. Disfigurations, fat distributions, there's a ton of diseases that can cause issues. And you should know all of these, okay? If I say, what's the problem because of a ruptured aortic aneurysm, you shouldn't have to think too hard. If there's a rupture in the aorta, there ain't no pressure to inject with. It's all just blowing the fluid into someone's chest or their abdomen, depending on where within the aorta it's happening. So, you know, you should be able to answer anything like this from common sense. Arthritis will cause bending of limbs, which means we're going to have a hard time accessing certain things, etc. Edema is generally going to factor just because of the fact that the body's swollen with water, and will play very heavily into where you want to drain from, what type of chemicals to use. If it's something like ascites, where you have you know, the generalized edema around the stomach, the abdomen area, that's going to cause problems. What if I want to, you know, try to push through that? I need to use a fairly large artery so I can build up a lot of pressure. And then obstructions and congestions. If there are lots of clots, femoral should not be used because those clots will blow into the head. Use the carotid to blow the clots down away from the head so that if there is a blockage, you can best jump over and inject via the legs rather than trying to get kinky using a facial or any other artery in the face. Again, those incisions on the cheek and the lower jaw going to cause some visibility issues. Trauma is going to definitely build into something, interruption from organ and tissue donation. But realistically, if we're looking at organ and tissue donation, it's nothing you should be able to go crazy with. This is bread and butter autopsy protocols. You jump in there and do business as normal. Legal requirements. For instance, military embalmers may have to follow a standard protocol regardless of situation. Standard protocol is a 6-point injection. Cause of death, manner of death. Just all these things that can pop into mind when you're given a multiple choice question or a multiple answer, select all that apply. You should be able to common sense eyeball your way through most of this if you've done your job studying well. Always assume, of course, body's infectious and contagious, final disposition and viewing will be delayed, and they're going to bring in a tank top. That way, you know, you can kind of gauge where you're making your incisions. Facial tissue distension, anytime you see this, anything to do with the face, for the most part, you're looking automatically at a restricted cervical injection. Rule of thumb. If anything's complicated, you're probably looking at restricted cervical injection. If there's facial discolorations, again, it's a complication. Raise the head and shoulders up, get the blood and the fluid out of the head and into the chest, let the gravitation do its job, and then inject via restricted cervical, drain from the internal jugular so you can get as much of the stuff out as possible. Probably going to be wanting to use certain types of drainage, which we'll study later. All these things need to be working in your head at all times. Volume and strengths of fluids. Well, on autopsy body, if you're going to be using a stronger solution than the 2%, medium, 20 index or whatever, you would do that for these cases. Long delay between time of death and prep, decomp, poison or burns. It says uremic poison because uremia is going to have nitrogenous buildup. So you're going to want to put stronger solution to help combat the fact that it's going to be neutralized by these nitrogenous byproducts. Skeletal edema, and obviously if you have any complications, restricted cervical is suggested for the best results. Isolate the head, inject the body separately. With multi-point injection sites, usually involve treatment of the head or appendages. Trunk distribution, if not sufficient, may be best solved with hypodermic injection. Now understand that does not mean just break out the hypovalve trocar and attack. It means if your trunk is not injecting very well, doing normal things, you will have to supplement it like you would in an autopsy, using a hypovalve trocar to inject the tissues of the trunk. Okay? You do not have the luxury of flaps. You're going to have to try to sneak these things within the tissue to make sure you're getting preservative in there. 3 methods to fix areas not sufficiently preserved. Sectional embalming. We tried the 1 point, we go on to a sectional. Never, ever, ever assume in a question that where it just says arterial, inject arterially again, or inject that section arterially. Do not take that for granted. You need to list it. That is the best thing to do first. If my right leg has not received fluid and the rest of my body has, the first thing I need to do is go right down to the leg and try to inject that via the inguinal or the femoral artery. The next thing I can do then is hypodermic embalming, and finally surface embalming using compresses, gels, etc. Once you've selected your site, elevate the vessel to the surface of the skin, place ligature around them, and then insert injection tubes and drainage devices. Ensure the injection tubes are clear before using them. You don't want to have a backup and have to take things out and risk harming the vessel. Okay? Locate vessels and sites for incisions by using their linear guides. You know, the anatomical guides, the anatomical limits are nice, but realistically, we're looking at the surface of the body. We want to be able to just kind of eyeball it and do what we need to do. Make the incision where vessels are nearest the skin surface. And when dissecting, you shouldn't be cutting and shredding muscles. You should be able to just kind of push those things aside. That's why it's called blunt dissection. Artery, vein, and nerve clusters run between muscles. So if you need to move a muscle out of your way to access a spot, say for instance down in the femoral area, you don't have to just cut the muscle and get it out of your way. You can kind of just move it to the side and find that little sweet spot between all the muscles. Make the incision in the skin, then use blunt dissection through the deep and superficial fascia. When I teach a lab, the only time that you touch a scalpel is to make the initial cut in the skin. Once you are through the skin, there is no need for you to be hacking with the scalpel. From there on in, it is blunt dissection. Being beginners, you should be very, very cognizant of the fact that while you are in labs, that you should be making your incisions maybe a little bit larger than a professional would, so you can start locating and visually seeing what these things look like. That's important as you learn. As you get better, you can make those incisions smaller and smaller and smaller. And it used to be the holy grail of embalming was the 1-inch incision, where you could inject and drain and do everything you needed from a simple, small 1-inch incision. I've tried that. It's a little funky to get used to. I don't do it very often. I do it to show off. Realistically, do things that are comfortable, okay? Because I get to work in a lab environment where I'm not having paying customers, I can take a bit more liberty showing off. The order in which vessels are raised varies, but there are 2 general rules. When a 1-point injection is selected, raise the superficial vessel first. And when it's a 1-point, insert instruments into the deepest vessel first. This is kind of one of the most no-brainer things you can think of. When you are working in one site, you want to get the top thing first to get it out of your way. Then, once you've found both of them, you want to take care of the deeper thing first so it doesn't get in the way of the top thing when you're trying to put something in it. Rewind. Try that again. When you're putting something into the deepest vessel first, that way you are, again, you're not getting anything in the way of what you're doing later. If you put the drainage into, say, working with the internal jugular vein, we put the drainage in there, okay, we put in an angular forceps. You're going to have to work around the angular forceps to insert your carotid arterial tubes. Much easier to put the tubes in and then put the drainage in afterwards. Make your incision into the artery, insert your arterial tube, tighten ligature around the tube to secure it in place. That ligature is going to form kind of like an O-ring so that any water pressure that backs up will hit that in case something gets around your arterial hemostat, which we'll talk about in a second. Always use arterial tubes slightly smaller than the lumen of the artery. You don't want to force the arterial tube. Some people use the term cannula. Arterial tube is the most proper term. Cannula typically gets the question wrong, okay? If you force things into the artery, you might rip the intima away from the tunica media, okay? Tunica, intima, media, adventitia, etc. Remember those? Should know what those are from anatomy course. And if you rip that tunica intima with your arterial tube, it might actually block the artery. And now you have to go past the blockage, make a new incision, etc. Okay? If you're using a sclerotic artery, attempt to find a soft spot, make the incision, and use an injection tube as big as possible to fit into the space that you have. If you break an artery, use hemostats to lock your ends down so you can grab things, put new ligatures on, proceed more carefully. At a minimum, you should have scalpels, double point scissors, or just good old-fashioned scissors, aneurysm needles, Bone separator, arterial tubes, drainage device, which are your drain tubes or angular spring forceps, straight spring forceps for packing and for various other items, and a groove director. Obviously, you can find some of these tools that are combination tools. Cut ligatures, you can get a good grip on the string to make a secure tie. That means make them large enough for you to actually play with, okay? So let's look at the vessels we use for our embalming. Common carotid artery, right and left. Largest vessel the embalmer can raise in the adult human body. Close to the arch of the aorta. If injected superior, head and face are embalmed. If injected inferior, opposite side of face, trunk, and appendages are embalmed. Considerations: large diameter. No branches except the terminal branches. We start injecting, it then splits. There's not a lot of things that split off that reduce the pressure for use. Very elastic, very rarely sclerotic. Supplies fluid directly to the head, close to the arch of the aorta, center of distribution, accompanied by a large, big-ass vein, and coagula are pushed away from the head. Precautions. Well, by using this, you might over-inject the head. Leakage is going to be visible, okay? You're making a cut right on the neck. It's going to get everywhere. You can mark the jawline or the face itself if you're not careful with instruments and it's pushing up against the skin while you're injecting preservative. Incisions used? Well, you can use the supraclavicular or the anterior lateral. The incision is made on the clavicle from a point near the sternoclavicular articulation and directed laterally. So if you put your finger right on that little notch above your clavicle, okay, where the clavicle meets the sternum, okay, you then make an incision on the clavicle bone itself from near this notch, not on it, but near it, and then direct it away from the midline of the body. So you're cutting right above the bone. The anterior vertical, from a point near the sternoclavicular articulation and directed upwards on the sternocleidomastoid muscle. So you follow the muscle up. Posterior vertical, or the posterior parallel, it's posterior to the sternocleidomastoid muscle, 2 inches below the lobe of the ear and directed towards the base of the neck. So you start from behind the ear, basically, right, 2 inches below the lobe of the ear, and then direct it towards the base of the neck behind the SEM muscle. The anterior horizontal, base of the neck from a point in the sternoclavicular articulation, and it is then directed posteriorly. So rather, starting at the notch of the clavicle and the sternum, instead of going up towards the head, you're cutting back towards the back of the neck. The semilunar, or the flap incision, this one's always fun for the newbies. You extend it from a point lateral and slightly superior to the sternoclavicular articulation and direct it downward on the chest wall, across and upward to a similar location on the opposite side. May look like a U or an inverted C. This is generally what we use when we're trying to use a restricted cervical injection. I don't like using this because it makes one of the most unsightly incisions ever. I'd rather do 2 anterior parallel incisions. Strap line for female, because generally this will be hidden by a bra or a dress or something. 2 inches lateral to the base of the neck on the line where the strap of the undergarment crosses the shoulder. So you have to be cognizant of where the undergarment would be. So suggested protocol for raising this bad boy. And this is important. So here's our table. Okay, here's our table. Here's dead guy. Take a position at the head of the table. Here. Not here. Okay, not there. Righty or lefty, doesn't matter. But at the head of the table. And then you follow the instructions. Turn the head in the opposite direction of the vessel being raised. So if we're raising a righty, we turn the head towards the left. And then follow the instructions. Just follow the instructions right down the list. If the vein is collapsed, perform 1 to 5 like normal. Palpate, which means you're going to go in there feeling for it. Okay, feel for the artery. Use your fingers. Raise and ligate it. Insert tube and begin injection. And when vein dilates, elevate and ligate. So basically, if you can't see it, this is another reason why I don't want to be going there just cutting everything in sight. Go find the artery. Start injecting, and then eventually when things start to push pressure, the vein will fill and you'll be able to find it easier. Another thing you can do is kind of pump the heart in CPR method. That might also force some blood into that vein so that you can see what's going on. You could also try raising the right arm so that fluid from the arm flows into the chest, thus also filling in the internal jugular. Generally, the right jugular is in direct line with the right atrium of the heart, which is the center of blood drainage. This is preferred for drainage over the left jugular. The left jugular does not link with the heart. It joins with the left subclavian, forms the left brachiocephalic vein, which then links to the superior vena cava. So not as easy to get stuff into the center of drainage. It is huge. You get direct drainage from the head. Everything just kind of clears right out, accompanied by the biggest artery that we can use in an adult body, and the jugular allows for easy removal of clotted material. However, leakage may be visible. Drainage instruments mark the face. Incision may be visible. All the same exact things that happen with the artery can happen with the vein. The facial, used on bodies when autopsies occur, carotids have been removed, or carotids are sclerotic as a result of stroke, can be felt in life by touching the inferior margin of the mandible just in front of the angle of the jaw. You will have to open the fibers of the platysma muscle to find this, okay? Incision is best closed with superglue because hiding the suture is a bit of a pain in the butt, and you don't want to risk the leakage of those non-visible sutures. So glue is basically the way to go. Axillary, armpits, continuation of the subclavians can be used to embalm the entire body. That's the least preferred one to use. Historically, this is the one we did use, okay? The incision was easily hidden. Close the arm, incision gone. We took drainage via the heart, doing a heart tap or direct heart drainage. We currently use this as a secondary point, supplies the arm and hand if injected laterally, supplies the whole body if injected medially. And with the axillary, we start injecting medially first. And the reason being is because if we are, his little buddy, his arms, very long arms, right? If we make our incision and we inject this way first, it's going to loop right around and then out is drainage. So what we want to do is we want to do the exact opposite. We want to put this in this way, so it's going to come in, it'll then loop up, do its thing, and distribute to the rest of the body accordingly. Precautions. Arm must be extended, especially if the vein is to be used. So what I typically have to do if I'm working by myself is I'll drop the arm over the side. I will then stand with my hip up against the arm to kind of keep it abducted from the body, make my incision, away I go. Artery is very small, vein is small. You have a danger of over-injecting the face because you really can't control what's going into the face. I mean, you're injecting towards the body, it just kind of happens. And it has a bunch of branches and anomalies. You know, there's a lot of stuff that's going on in your armpits in regards to the arterial side. Very, very difficult because everything's going everywhere. The incision, arm should be abducted, made parallel to the linear guide, which is the anterior margin of the hairline of the axilla. And review protocols at home. Brachial supplies arm and hand, can inject the entire body. This is going to be slow and difficult because you're not going to be able to build up a lot of pressure. Incision may be made anywhere along the upper half of the linear guide, but the proximal third is preferred closer to the trunk than the elbow. Okay? It can also be raised where it bifurcates into the radial and ulnar in the antecubital fossa. You could also do direct injection for those arteries, so you can raise both of them and then shoot, you know, both sides of the hand that way. This eliminates the need to suture in the wrist area for shirts, you know, other visible things. To raise the artery, arm should be abducted away from the body so it can work and kind of stretch things out so you can find it. Radial, kind of look this over, okay? It just kind of is what it is. If you're having some issues, you can place your thumb over the ulnar, the other one, while injecting the clear discolorations of the hand. By closing the ulnar, you also prevent short circuiting. So this doesn't, you know, bounce back around and come back out. Ulnar, again, general information. Femoral, second most frequently used set of vessels. For some people, this is their primary injection site. I feel your pain. Sometimes referred to the iliofemoral. When it directed inferior, okay, you shoot down, it supplies leg and foot. When you shoot up, it supplies the other leg and the whole body. Artery's fairly large. The incision's not usually visible on most people, depending on what you're dressing them in. Both sides of the head usually receive even distribution of solution, which is especially important when using active dyes. Accompanied by a fairly large vein, it can be used to do a clean embalming with no blood on the table. Head and arms can be posed without further manipulation after embalming. Some serious perks to using this. You set everything up, you inject it, and away you go. One of my early proctors was a guy by the name of Mike Hook. He owned Hook Funeral Home, or his dad did, and Mike sold it to the guy I ended up working for, Jim Reese, which is how I met Mike. And Mike is a hell of an embalmer. I mean, just really one hell of an embalmer. And he always started with the femoral. And it was because he was taught that, hey, if you can't do it with the femoral, then you can go make the cut in the neck. But otherwise, you don't have to worry about it because it's going to be hidden. So if you can get away with it, start with it, and then make the other incision as necessary. But make sure you take into consideration these days all the criteria that we discuss about the embalming analysis and what the benefits and disadvantages are to using anything. Problem is, if you have sclerosis, the femoral is a problem. Vessels may be deep, especially on obese bodies. You have no control over what goes into the head. You fire it north and you forget about it. Coagular can be pushed into viewable areas. So as you're pushing the blood from the hip area up into the head, you run the risk of blocking something up there that you might not want to block. And large branches down in the leg may be mistaken for the femoral artery. That happens with some regularity. You should, review the stuff in regards to making the incision and the protocol. You can read at home. You can use, obviously, the vein for drainage, assisted by gravity and draining. You have, the weight of the earth kind of pulling things down and away. Let's keep going. Precautions. Well, the weight of the viscera can restrict drainage from the upper portions of the body. So as it's pushing up and trying to come back around, there's only a fixed set of pressure coming around towards the drainage side, which means if it's not enough to kind of push through the weight of the viscera, it will back up and cause swelling in the upper extremities and face. Abdominal pressure from gas or ascites can exert pressure and restrict drainage. Vein is deep, okay? If you thought the artery was fun, this is below the artery. Many tributaries flow into the femoral vein. Clots in the right atrium and the upper areas of the vascular system may be difficult to remove, and pressure on the heart from hydrothorax may make it difficult to establish good drainage. So this is a candidate for your split injection. If you're having all these problems, open up that right internal jugular and watch the fun fly. Popliteal, secondary injection on the site, on the leg below the knee. We only do it in special circumstances. I would probably greatly prefer I inject from a tibial rather than a popliteal. Just don't want to have to articulate the leg accordingly. May be easily accessed in certain arthritic conditions because the leg is all bent out of shape. Accompanying vein is not used at a drainage site. It's too small to be of any worth. Talks about the incisions and how to make them. The anterior and posterior tibials supply solution directly below the knee into the foot. The arteries are relatively deep. Suturing is a problem because the skin is usually tight. Leakage, as a result, can be an issue. May be impractical due to sclerosis, gangrene, or other problems. Treatment usually is accomplished by hypodermic injection, surface gels, and plastic garments. Know where the incisions are with the anterior versus the posterior tibial, okay? Abdominal aorta and thoracic aorta, well, these are right above your spine, so fairly deep, and all your guts are in front of them. May be used for injection in autopsy or donation case, where we have easy access to them as a result of the procedure. We generally would like to use these in infants just because of the fact that we have tools that will fit there in not many other places on infants and children. Drainage can be taken from basically wherever we want, femoral, jugular, even the vena cava. So it tells you the incisions. Know these cold. On the infant, the abdominal aorta, incision is made on the midline of the body, a few inches below the xiphoid process of the sternum, so the bottom bony projecting part of the sternum, and extends inferiorly for about 4 inches. Intestines are retracted to expose the artery and vein. With the thoracic aorta in the chest, incision is made along the midline of the body down the center of the sternum. Sternum is still cartilage at this point. Sternum is then retracted and held in the open position. You're going to need some retractors for those. Pericardium is then open and the heart is moved to one side. Artery is going to be anterior to the spine, attached to the arch of the aorta. Iliac, kind of the same exact thing as the femorals, okay, supplies fluid to the lower leg and anterior abdominal wall. Tells you where the incision is, over the inguinal ligament. No-brainer. Internal iliac is a branch of the common iliac. Injection supplies solution to the glutes and peroneal cavities. The inferior vena cava, a site can be used for drainage when a partial autopsy has been performed to create intermittent drainage. Break out the hemostats and clamp them on and off. Right atrium of the heart, direct heart drainage, the old heart tap. Trocar is inserted into the right side of the heart. But to do this, you'll need to inject a ½ gallon to a gallon of solution prior to piercing the heart with the trocar. You want to charge the system up so when you go to puncture it, it punctures nice and neat into the heart and doesn't give you issues with sliding off and bumping and poking holes and things it shouldn't. Tells you to insert the trocar at the standard point of entry, 2 up and 2 over. It is directed into the mediastinum and intersects a line extending from the lobe of the right ear to the left anterior superior iliac spine. If you simply direct the trocar towards the right earlobe, the point should pass right into the right side of the heart. Usually wise to attach some clear tubing so that you can see when you've actually burst the heart with it so that you don't continue pushing. Historically, this is what was used when embalming in a residence. Now, if you want to practice this, okay, if you want to practice this even on your paying clientele, the way you practice it is once you are done arterial injection, you follow these steps right here as your initial aspiration step. So you finished everything, you insert at normal point of entry, you direct your trocar accordingly, and as soon as you get that burst of deep cherry red, that was the heart tap. And you do that 30 or 40 times until you get good at doing it on the first shot. And when you can do it on the first shot like 10 or 12 times in a row with no issue, you're probably good enough to start doing it regularly. Because if you have a problem with it, you pop a hole in the arch of the aorta or the descending aorta, you're pretty much going to do a multipoint whether you like it or not. So making your incision into the artery or vein, you can use scissors or scalpels. Personally, I use scissors, nothing but scissors. So the transverse, okay, most common, edge of the vessel to just past the center of the vessel. So if I draw my vessel and I make my cut, I'm going to basically cut a straight line, probably, that's a little bit too much. I'll probably like to right there. I want at least enough so it doesn't snap in half and cause me issues. Longitudinal. You cut parallel down the center of the vessel. Not recommended for sclerotic arteries. Can be used to place 2 tubes in at the same exact time. I used to like doing that when I was embalming regularly. Combination, useful for veins, especially when using a drain tube, so you basically mix and match what you want. The T incision, well, guess what? Looks like a T, okay? That's a real hard one. The double T, oh my God, really? Looks something like that, okay? And the wedge. So I make my cuts, and then I form a wedge. I have played with this on occasion. I'm not going to say I like it or I don't like it, but I have played with it, and I still prefer my good old-fashioned right to a little bit past half center. Folks, thank you for your attention. We will see you next time.